Courtney DiNardo here from MD Anderson in Houston, Texas. My privilege to talk to you today about some of the current and emerging roles of biomarker-directed therapeutic approaches for patients with AML. And I'll just say one word to kind of overlay all of this, which is that we are becoming increasingly fortunate that we have individualized therapies. We have targeted therapies. Precision medicine is becoming more and more a reality. So some of the updates you can see here is for patients with FLT3 mutated disease. So for our younger patients who are FLT3 mutated, which is about a third of them, so a decent chunk of our newly diagnosed AML patients have a FLT3 ITD mutation. We now have updates from the Quantum First study, which was a randomized study of standard intensive chemotherapy with either placebo or quizartinib, showing that we have an improved overall survival. And this has led to the approval of quizartinib to incorporate for our FLT3 ITD mutated patients at diagnosis. And one thing people often are saying, is, well, midostaurin is what we typically have used, right? Based on the Ratify study, which you can see on the left. When you add midostaurin, the complete remission rate is a little bit higher, a clear, improvement, although somewhat incremental, but clear improvement in overall survival with midostaurin compared to placebo. And when I try to superimpose the Quantum First graph, it kind of looks the same. But I think one thing that's important to remember is even though these studies, on first blush are similar, there's two main differences. One is that the Ratify study was only for patients who were 60 years of age and younger, whereas the Quantum First study allowed people up until the age of 75. And then the other main difference is that midostaurin is effective for both the ITD and the FLT3 TKD mutations. So about a quarter of the patients that were treated in the Ratify study on the left were FLT3 TKD, and those patients don't have as poor of a prognosis. So when you think about it that way, so if you're kind of now looking at the Quantum First study on the top right, only patients who are under 60 years old and who only have, remember the FLT3 ITD, it actually starts to look a little bit different. And you can potentially see that there's more of a benefit with the addition of quizartinib. And then, conversely, you look down to the bottom and you see that patients who are over the age of 60, unfortunately, don't seem to have that same benefit from the addition of quizartinib. And I think some of that just has to do with the challenges with giving older patients intensive chemotherapy, which is why, our field is definitely transitioning towards lower intensity combinations and effective strategies for our older patients. The next step is, looking at, why is it, or is it true that patients that are getting quizartinib are getting better remissions, deeper remissions? And so MRD is becoming more and more important in analyses of AML studies. And so this was an update from Sasha Pearl at ASH showing that, at the various different time points, of course, if you become MRD negative, you're clearing that clone. Not only, are you in a morphologic remission? The hematopathologist can't see any leukemia, but you've actually cleared leukemia even further using a very sensitive assay, like 10 to the -5, -6 assays. You do better, right? So not surprising, if there's still residual disease that's detected with MRD positive, your outcomes are not as good. And that's true at every different time point, after induction, after consolidation, after completion of therapy. So the obvious question is, does quizartinib help you attain deeper remissions? And so that's what's shown here, and that is indeed true. So looking at these blue bars, whether, blue is the patients who are getting randomized to quizartinib at each different time point, after induction, after consolidation, after completion of consolidation, you have more patients getting deeper MRD negative status. And then along the bottom, you can see that at the end of the induction consolidation treatment, over half of the patients, 56% of them, are becoming MRD negative on the quizartinib arm. MRD wasn't a thing back when we did the Ratify study, so we can't really compare it to midostaurin, but we certainly can see that the addition of a FLT3 inhibitor is attaining more MRD negative remissions, and hopefully more patients being cured because of that. So the conclusion of kind of the Quantum First updates over the past year is, one, there is prognostic utility of obtaining MRD measurements. We realize, more and more that MRD is important and can help us identify who is going to do best with treatment, as well as in the future help us identify how to treat people differently because of it, and that quizartinib is associated with deep responses and more frequent MRD clearance.
Just kind of curious, and I'm sure most of your patients go on trials, but in situations where you have a patient who's eligible, who's got an ITD mutation, is eligible to receive both quizartinib as well as midostaurin, do you have any preference?
We have increasingly been using quizartinib. I think there's comfort in what so I feel like in the community they're still using a lot of midostaurin over quizartinib. I find that the GI adverse events and the rashes and a lot of the challenges with midostaurin are far less frequent with quizartinib. The main side effect with quizartinib is more cytopenia. So you just have to be aware that the myelosuppression is a little bit more prolonged, and help manage that. And QTC, of course, you have to monitor for QTC. So it's a slightly different profile, but we've increasingly been using quizartinib and being happy with that.
In terms of the quote GI issues with midostaurin, is it? I've heard that it smells bad. Is that what it's about?
The pill itself smells bad. One of my patients calls it her skunk pill because it really just has an unpleasant odor. So that causes some of the nausea, just as you take it, but the pill itself also does seem to be associated in many people with just more GI complaints.
So let's get on to this next part because this is super cool. This wild type thing.
Yes, and so the Kiwi study is a study that everyone is trying to grapple with a little bit and try to figure out what to do. So the Kiwi study is from Spain. This is a Spanish cooperative group study looking at using quizartinib, which is a selective FLT3 ITD inhibitor, but does have kinase activity, for patients who are FLT3 wild type, right? Which we didn't really think made sense, but they have this rationale, and they did a clinical trial. It was a 2-to-1 randomization. So you get 7 and 3 with either quizartinib or placebo. So very similar to the Quantum First study, but now we're looking in a FLT3 ITD wild type population. And essentially what they identified and reported on a year or two ago was that patients who received quizartinib actually did better. The 2-year overall survival was 63% versus under 50%, 47% with the placebo. And newly identified in what they reported this year at ASH was there's this FLT3-like expression profile that about half of the patients have, and that was what helped predict who was going to respond to quizartinib or not. And so if you did not have that FLT3-like signature, you didn't need quizartinib. It didn't benefit you, just like you would expect a wild type patient wouldn't benefit from quizartinib. But the FLT3-like patients really did benefit, and so that was highlighted. And the challenge is that you can't really identify who the FLT3-like people are just with standard mutational panels, which is what we're using now to decide how to treat patients. It was true that more patients with NPM1 mutations and DNMT3A mutations were FLT3-like, but that wasn't universal. And there were patients in all of the different prognostic categories that were in both the yes and no FLT3-like. And so the challenge is trying to figure out, can we use this? How do we identify who is going to be FLT3-like to be able to incorporate quizartinib? But it is super interesting, and it makes us, of course, realize that we think we know how a drug is working, and we don't always, and there can be other mechanisms. This story reminds me a lot of the pH-like story in ALL, where there are patients who don't have a BCR-ABL, don't have that Philadelphia chromosome, but yet they have an expression profile, a pH-like profile that shows that they actually do respond better to tyrosine kinase inhibitors. So it's a very similar story, and so we're trying to figure out how to actually incorporate this in the clinic.
I was talking with Novel about this, and I was recollecting, I think it was the sorafenib study that I think showed benefit even in, quote, wild type patients, and I guess I never explained that. Can you talk a little bit more about what FLT3 is and pathophysiologically, not just clinically, but biologically, what goes on in these patients?
Yeah. So first of all, it's one of the most common mutations in AML. So FLT3 and NPM1 are two of the most common. So about a third of our patients will have a FLT3 mutation, either in an ITD, which stands for an internal tandem duplication, or a TKD, which is the tyrosine kinase domain. And so the ITD is exactly that. You get these duplications in the FLT3, which leads to a proliferative phenotype. So FLT3 is involved in the proliferative pathway. So when you have these ITDs, it often leads to kind of a patient that is presenting with AML with a higher white count, with a more kind of aggressive physiology. And that's why the FLT3 ITD patients have historically been more high risk. They're the ones presenting with the white count over 50,000, where it's an emergency. You've got to calm things down because they're having kind of leukocytosis complications.
I guess it's too early to say what the magnitude of benefit might be in these people, or even if it's there, I guess, right?
Yeah, I mean, the challenge I have with the incorporation of quizartinib to standard 7 and 3 is that there are a lot of different things you can add to standard 7 and 3 and have patients improve. So, for instance, there's also discussion of adding fludarabine or cladribine. There's the Polish study adding cladribine to standard 7 and 3, and patients do better. There's a lot of clinical trials here throughout the United States adding venetoclax, right? We use venetoclax with lower intensity therapy, but adding venetoclax to intensive chemotherapies is also incredibly effective. And I wouldn't be surprised if some studies are positive, in the coming years in terms of that as well. Our own institution has published phase 2 studies of FLAG-IDA venetoclax and CLIA venetoclax. So our regimens of these things, which show, 80-85% response rates, MRD negative rates. So I think the challenge is knowing, what to add in which patient, because adding something to standard 7 and 3 is almost certainly going to benefit a certain percentage.
Okay, please continue.
So the summary of the Kiwi results is that there is kind of surprising but initial evidence that quizartinib with intensive chemotherapy may benefit patients who are FLT3 wild type. And my second comment here is it's hard to obtain these expression patterns. It's not only hard, it's essentially impossible. So we can't really be using these expression patterns yet to identify who should or who should not get quizartinib, but it really is part of this growing body of evidence suggesting a more personalized and targeted approach for AML is increasingly possible as we have these new therapies. And there is also another FLT3 inhibitor, of course, gilteritinib, which is another kind of second generation. This is more of a kind of pan-kinase also that hits both the ITD and the TKD. We are waiting for the results of a large randomized clinical trial of 7 and 3 with gilteritinib. There is a phase 1b study that Keith Bratz has presented and published in JCO last year, I believe, highlighting the fact that this will probably work too. So gilteritinib is approved only in the relapse setting as a single agent right now, but in combination with intensive chemotherapy in the phase 1b non-randomized component, patients, both FLT3 wild type and FLT3 mutated, received gilteritinib and appeared to do better both in terms of response and overall survival. And so we're kind of all eagerly awaiting kind of the results of that larger 7 and 3 gilteritinib clinical trial. But gilteritinib, it's the monotherapy relapsed approval right now. But a big story over the past year was the results of the Morpho trial, which looked at, is there a role for using gilteritinib in post-transplant maintenance? So the Morpho study was a very large study that enrolled patients who were in a remission that had received only 1 or 2 different induction consolidation cycles. 30 to 90 days after transplant, they should be starting gilteritinib or placebo. And an important kind of secondary analysis of this study was looking at the role of MRD. So I talked about MRD already with the Quantum First study. Now we're talking about that same very sensitive FLT3 MRD assay in this study. And actually about half of the patients who were enrolled in this study were MRD positive, either right before or right after transplant. And so, there was this collective groan when this data was presented, because the primary objective was relapse-free survival for the entire population. And the hope was that gilteritinib was going to improve relapse-free survival across the board. And it was just shy of being statistically significant with a p-value of 0.0518. And so the study was negative. And so if you have, your one-liner, this study was negative. But what I think is potentially the right way to use this, again, we're talking about MRD-directed therapies and the importance of MRD in those 50% of patients who had low-level FLT3 ITD mutations identified. Those were the patients that benefited from 2 years of gilteritinib. And so along the top in this, curve along, you can see there's a clear benefit from adding gilteritinib in those patients who were MRD positive, whereas if you didn't have any disease, if you were cured, you didn't need 2 years of chemotherapy. And so I think, if you look at it that way, it's again highlighting the fact that, we're doing better with personalized medicine. I love this slide because it shows that MRD is important, but also the level of MRD is important. So when you look at kind of how much residual disease you had, you could detect it at 10 to the -4, -5, -6. You are increasingly likely to do better, the less residual disease you have, which of course makes sense. And for all of those patients, by adding gilteritinib, you're improving the outcomes. And then the last thing that I think is really important to recognize is, again, FLT3 mutated patients have that more proliferative phenotype. And so relapses often happen fairly quickly, especially in that post-transplant setting. And so if you are kind of thinking, yes, I'm going to add a FLT3 inhibitor as maintenance for my patient with FLT3 mutated disease post-transplant, but you're waiting, 6 months, 9 months, it's too late. They've really already relapsed by then. So it's important to start that therapy in a patient who has MRD detectable disease as early as you can, as early as 30 days once they've engrafted and counts have recovered and they're doing well. And so I think that's just a really important thing to keep in mind, because oftentimes we're waiting in the peri-transplant setting to start a maintenance approach. There is additional evidence about the role of adding gilteritinib in that post-transplant setting. So this was the Admiral study I had mentioned. Gilteritinib is approved as a single agent in the relapse setting. So that's because of this study, the Admiral study, which highlighted that gilteritinib was not only as effective, it was more effective than intensive chemotherapy or other approaches for people in the relapse setting with FLT3 mutated disease. And there was a subset of patients who went to transplant in this study, 64 out of the original almost 250 that got gilteritinib. And in those patients that went to transplant, 40 of them restarted gilteritinib and 24 of them did not. And the patients who restarted gilteritinib did better overall. And this is a biased analysis. And this, of course, is just kind of additional evidence to suggest and highlight the fact that patients who, are FLT3 mutated that are going to transplant, post-transplant maintenance, especially if they have MRD positive disease, is definitely of benefit. And again, just highlighting what I have mentioned already, any level of MRD in patients with FLT3 mutated disease will impact relapse-free survival. You want to clear that as much as you can. If you have detectable MRD, that is where there's clear evidence of improving outcomes in patients receiving gilteritinib post-transplant. And the sooner you can start, the better your patient will do, because relapses happen fairly quickly post-transplant.
So just to clarify,
Yep.
have most of these patients received midostaurin previously?
Many, it depends on the part of the world that these patients were treated in. So in the US, yes, many of them had. In Europe, some patients had, and then in Asian countries, very few had. So that is something that has been looked at, and really it was of benefit in MRD positive patients across the board.
That's interesting. All right, keep going.
just the long and short of it is that TKDs are not nearly as bad as the ITDs. And so it's a FLT3 mutation for sure, and you can target it and you should target it, but it's really the ITD patients that have the highest risk of relapse and the highest risk of poor outcomes. And then I have an update. This is the only update of a triplet study that I'll talk about today. But this is the addition of adding either actually an IDH1 or an IDH2 inhibitor, ivosidenib or enasidenib, to the backbone of HMA and venetoclax. So in this case, the hypomethylating agent is oral decitabine. So one of the neat things about this triplet trial is that it's all oral. So oral decitabine, venetoclax, and either the oral IDH1 or IDH2 inhibitor. The oral decitabine is given for 5 days per cycle. Venetoclax is only 14 days. And so, as many of you know, the label of venetoclax is to give continuous venetoclax, which is really not what's done in the community and not the best for your patient. So when we are designing triplet trials, almost always the venetoclax is given for 14 days. And then often in patients in a remission, you can shorten that later on in subsequent cycles. But just to highlight that study schema, we've treated now over 50 patients, both newly diagnosed and relapsed refractory patients with IDH1 or IDH2 mutations have been enrolled in this study. And for newly diagnosed patients, we are seeing response rates, composite remission rates of over 90%, 85% are becoming flow negative for MRD assays. And so just as a reminder, with the AZA-VEN study, the VALI-A study, about 40% of responding patients became MRD negative. So it seems like we're, about twice as many patients are becoming MRD negative. And we're not seeing early mortality. I think a triplet trial really depends on what that third agent is. The IDH inhibitors don't cause a lot of myelosuppression. They're not really cytotoxic, so we're not seeing a lot of increased toxicity by doing the addition of the IDH inhibitors. In the relapse setting, we're seeing composite remissions overall of about 50%. When you kind of think about how well either AZA-VEN or an IDH inhibitor is going to do in the relapse setting, it's about 40% composite remissions have been described. But what's kind of important to remember is how heavily pretreated this population is. So when you look at those patients who, haven't received prior venetoclax or who haven't received, multiple lines of therapies of prior IDH inhibitors and venetoclax, about 2/3 of patients are responding. And so I think this really does highlight that this is an effective treatment strategy. And I think you'll be hearing more and more about some of these, HMA-VEN triplet trials trying to get, deeper remissions and hopefully improved outcomes. There is another IDH1 inhibitor, olutasidenib. So this is a study that led to the approval of olutasidenib in the relapsed refractory setting as a monotherapy. There were 8 different cohorts, but the largest enrolled and the one submitted to the FDA was the relapsed refractory cohort of AML patients. So about 153 patients were treated. And so one of the questions in the world of, IDH1 mutated disease, which is about 10%. So about 10% of AML patients will have an IDH1 mutation. Is, should you use olutasidenib or should you use ivosidenib? And there's no head-to-head trials, of course. And so we, kind of just look at the studies that were done and try to make comparisons and identify. So when you look at the median survival of olutasidenib, it was just under 12 months, 11.6. It was 9 months for ivosidenib. When you look at the non-responders, those curves are very similar. And so there is some, I think, appropriateness of comparison here. What is really interesting is that the response rates overall are incredibly similar. So the composite remission rate is about 1/3. The overall response rate is in the 40s for both of them. But what's really different is the duration of remission. And olutasidenib has kind of double the duration of a response rate or a composite remission. And so the question is, is this a better drug or is it just a different patient population? And it's really hard to know. I'm not entirely sure. So kind of looking through at the comparison of the IDH1 trials that led to the approvals in the relapse setting, They were both about 150 patients. I've kind of highlighted the differences. There were more patients on ivosidenib who had poor risk cytogenetics. There were double the number of patients with P53 mutations. More patients were kind of multiply relapsed instead of just in their first salvage, and more patients had had a prior transplant. So it may be that the ivosidenib population just, was a higher risk population. And that's why we're not seeing as long remissions. We know P53 mutated patients don't stay in remission very long if they obtain a response in the first place. But on the flip side, there are very few things that work in a post-venetoclax setting. We and others have published outcomes in patients that fail HMA-ven regimens. Their median survival is like on the order of weeks, and really limited survival outcomes with any sort of effective therapy, unfortunately. But there is a small sub-cohort analysis of the 17 patients that had received venetoclax that then went on olutasidenib, and it's really quite impressive, actually. The overall response rate in these patients that had failed venetoclax and then went on this study was 40%, and the median response hasn't been reached when it was last updated, and it had been ongoing for over kind of a year and a half. So there is, to me, some truth that maybe olutasidenib is leading to deeper remissions and maybe a quite effective drug. Yes.
I don't know, for some reason, you probably never heard of the Stampede trials out of the UK in prostate cancer. These wild trials with like so many arms and all. I was just jotting down here on my pad here. First of all, what do you think? I know this trial would never be done, like a 6-arm trial. Triplet versus doublet versus single agent. I don't know what the short name for Olu and Ivo.
Yeah.
Any thoughts about what it would show? And also, right now, more than data, what's your gut about the best long-term strategy? Because you brought up the issue, maybe sequential. You got to look at that. So, you'd have to look at a lot of things, but sort of globally right now, what's your intuition about where it's going to land?
Yeah. I think you're right. In a perfect world, we would have a Stampede-like trial where we would have arms of, Aza-Ivo versus Aza-Ven versus Aza-Oluta versus triplet combinations to figure out which one really is the best approach. The challenge is only 10% of AML patients have an IDH1 mutation, and AML is a rare disease, right? So when you are trying to design these trials that would need hundreds of patients in each arm to show superiority, there's just no way. Which is a shame, because it would be really nice to have a definitive answer. I've presented, in cooperative groups, doing at least 3-way randomization, Aza-Ivo, Aza-Ven, Aza-Ivo-Ven, because I do feel like that the triplet of Aza, Ven, and Ivo is leading to deeper remissions in a well-tolerated fashion. But it's hard because, patients that get either azacitidine and venetoclax or azacitidine and Ivo, those are approved frontline regimens and they do pretty well. So, that incremental benefit to prove in a randomized, 3-way clinical trial would be really tricky. But that's my bias is, you have about 2/3 of patients responding to either Aza-Ivo or Aza-Ven in the frontline setting. When you do the triplet, you're getting like 90% of patients responding. So you're capturing more responses at the beginning, and it seems like we have more patients obtaining deeper remissions early on. Just because you start with a 3-drug regimen doesn't mean they need to stay on that forever and ever. So part of what our field has to do is really help identify, maybe 1 or 2 induction type cycles, and then you move to a more ongoing maintenance strategy where they're getting maybe 2 or 3 drugs or shorter regimens. So this is still being designed, but I do believe that, adding these therapies together as opposed to sequencing them is going to be the optimal approach. Whether to use ivosidenib or olutasidenib, that one's tricky too, because all of the triplet trial data and everything we've come up with so far is with ivosidenib, but olutasidenib is as good, if not better. And so we really need to be kind of incorporating olutasidenib into our clinical trials. And we actually will be opening a triplet trial with Oluta to get some experience with that in the coming months.
Any sort of biologic, potential explanation if Oluta does have greater activity, greater duration of response, et cetera? Is the kinome different? Is there anything clues there about why it would be?
I Nothing that I have seen that is compelling to really explain a difference. Olutasidenib is it may kind of fit into that pocket where it binds because IDH is an enzyme, so it's kind of blocking. Maybe it fits better. It's the only main difference, in terms of kind of nuances of the compound is olutasidenib is a BID drug, so you take it twice a day. The half-life is shorter than the once a day ivosidenib. The other thing that's different, I don't think I'm going through it in slide detail, so I'll mention, is the side effect profile is just a little bit different. So they both can cause differentiation syndrome, of course. But ivosidenib has QT prolongation issues, so you have to be monitoring EKGs. Olutasidenib has transaminitis issues, so you have to be monitoring LFTs. And so there is kind of a little bit of a difference there.
Interesting. So let's get into the next great thing that I think oncologists better start learning about real fast.
That is exactly right. So this is the, as you said, the next new thing for AML are the menin inhibitors. So no, there are no menin inhibitors approved right now for use in the clinic, but these are small molecule agents. They're pills, and they are differentiating agents. So just like the IDH inhibitors, ATRA, arsenic for acute promyelocytic leukemia, this is another class of differentiating agent therapy. You can see this schema. This is specific to revumenib, but they're all the same. These menin inhibitors go in and they kind of bind the menin protein, and they prevent this kind of leukemogenic complex that is created that patients who have KMT2A rearranged leukemias, so that used to be called MLL rearranged, the 11q chromosome translocations, and then NPM1 mutated leukemias also have this upregulation of this complex, which leads to kind of this upregulation of HOXA9 and MEIS1. So again, we're going back to expression signatures where you can identify patients who have this kind of upregulation of this pathway. There is this expression profile that identifies that patients with KMT2A rearranged leukemias and NPM1 mutated leukemias are most likely to benefit from menin inhibitors, and that's where the initial clinical trials initiated. But actually, we're realizing that there are other subsets of AML patients with, for instance, NUP98 translocations that are often seen in pediatric patients. And so we're kind of still learning which patients are most likely to potentially benefit from menin inhibitors. But this is a really exciting new foray and new kind of entire class of effective AML strategies. So you can see that there's 5 or 6 different menin inhibitors that are currently under evaluation in the clinic, made by different industry partners. The first 2, revumenib and ziftomenib, are the farthest along and have had the most data presented. Revumenib in particular has already been submitted for FDA filing, and there is a PDUFA date in November. So actually in only potentially a couple of months, we may have our first menin inhibitor available in the clinic. And just to highlight, some of the data, this is with ziftomenib, one of the menin inhibitors, and they're all being evaluated initially as monotherapy in the relapse setting. As that's how clinical trials work with novel therapies. So about 40% of patients respond, and the responses are unfortunately not as durable as we would like. So in general, the duration of remission with a menin inhibitor as a single agent is about 6 months. Resistance tends to happen pretty quickly. This is not so different really than FLT3 inhibitors and IDH inhibitors, where you're looking at a single agent of a targeted therapy in the relapse setting. So actually quite similar when you look at response rates and things. And so this is an example with ziftomenib, and again, highlighting that these are differentiating agents, so you don't see a lot of myelosuppression. You see count recovery. You can see differentiation syndrome in about 15 to 20% of patients. Revumenib is the other farthest along menin inhibitor, so there's some data shown here. Pediatric patients, it's important to highlight, have KMT2A rearrangements. It's one of the most common AMLs in infants. And so what's interesting for us in the world of adult leukemia therapy is we've been partnering with pediatricians a lot more than we did before to enroll patients on these menin inhibitor studies, because there is definitely a need for pediatric patients to have access to this. Again, highlighting that these are patients being enrolled in the relapse setting. They've had multiple lines of therapy. Many of them have failed venetoclax, like we've said before, really highlights a population that doesn't do well with really anything that we have available. And again, we're seeing an overall response rate here of over 60%, composite remission rate of 23%, a median duration of about 6 months. So again, these single agents work, but don't work that long. So hopefully you can get your patient to a transplant. In the future, we'll be designing clinical trials of combinations where most likely these agents will work in a more durable fashion. So again, just highlighting the fact that these are not particularly cytopenic. We don't have a lot of challenges with that, but we do see QT prolongation and differentiation syndrome with all of these menin inhibitors. There have been quite a few patients that have been able to transition effectively to transplant. So you get a responding patient, you're able to get them to that transplant, especially with a KMT2A rearranged leukemia. They're really high risk. You often haven't had the opportunity to go to a transplant because they are very adverse risk. They don't respond well to standard therapies. And so this is really exciting. The KMT2A rearranged leukemia group is even smaller. It's about 5% of leukemia patients, but there's a clear need that we need these inhibitors in that population. And then NPM1 mutated disease is one of the most common. Many NPM1 patients do well in the front line, but when they relapse, they do just as bad as anyone else. So there's definitely kind of a need for both of these initial AML cohorts. And then just to highlight the third menin inhibitor that has clinical data that has been presented, this one is still a drug name with lots of letters and numbers, J&J 752-76617. But again, just highlighting, that patients are heavily pretreated. Most of them have had prior venetoclax before, and yet we're seeing response rates of about 50%, composite remission rates of over 20-25% in both the KMT2A and the NPM1 mutated population. We don't see cytopenias. We do see differentiation syndrome, and responses last for about six months. And the first clinical trial that has been presented thus far is, again, a triplet. This is another all-oral triplet where it's oral decitabine with venetoclax and ASTX. Again, the venetoclax is only given for 14 days. We don't want to kind of compound myelosuppression and toxicity issues. Only 9 patients have been presented so far. Again, very heavily pretreated. The majority have had venetoclax. The majority here have already failed a transplant also. And now we're seeing an overall response rate of 100% with a composite remission rate of 44%. If you include the CRPs, you've got a whole lot of patients with kind of pretty deep remissions. What we don't know in this study is the duration of remission. That hasn't been reported yet. It's such an early study. So my hope is that, once we're doing these combinations, not only are we seeing more responses, but we're seeing them last longer. And so menin inhibitors are just really exciting. I really do hope that we'll have the first one approved and available in the clinic, by the end of this year. And then, just like all of the other targeted therapies that are available and approved as a single agent in the relapse setting, we got to figure out, how do we make it work better? What's the right way to use these combinations and improve the outcomes even further? So I think this, what's called the SAVE trial, the all oral triplet is a really exciting preview to that. And so that is the overview. So we have more and more AML therapeutic options, which is great, but it makes it a little more complicated. AML is a rare disease, and you've got to figure out, how to use the, dozen or so new trials that we have, new treatments based on, the specifics of your patient. So so that's exciting. Increasing use of MRD, how deep a remission your patient is in really can help guide treatment strategies. We have more and more trials showing evidence of that. And menin inhibitors are just the next new thing, and we're really excited about those too.
So just a couple of final questions. Seeing those trials with the oral decitabine venetoclax brings that up in my mind because in general, when I've been asking leukemia investigators about using that outside a trial, they like don't exactly jump on it. I don't think they're even doing it. A lot of people, and I was curious whether you are and why the hesitation.
I guess oncologists are pretty good rule followers. And so oral decitabine is approved right now only for MDS. So it is increasingly used, I think, in academic settings and in the community for MDS patients. But it just hasn't really caught on yet in terms of use in AML. And some of that is, insurance reimbursement. You can't get oral decitabine outside of a clinical trial for AML patients in many places. Um, I sometimes try because my patients are, of course, very interested, right? They would, of course, prefer an all oral regimen instead of coming to the clinic, for 5 days in a row every month. But so I think some of it is, just awareness and thinking about, but I think the other big part is the reimbursement issue.
No, I mean, I totally get the reimbursement thing for
Yeah.
sure, but I
Yeah.
still hear people conceptually questioning it. And the only thing look, I know that it was such a great, advance, but,
Mhm.
it's still, I would say, kind of in the palliative world. I mean, at least pharmacologically, it certainly seems like it would be the same. I don't know. I guess, anyhow, just, I
So
don't know,
yeah,
just
so
wondered.
pharmacologically, it was approved based on the fact that it is 99%, equivalent, right? So it's hard to argue that, it leads to the same kind of effect in a patient. So but it is true, I will say, I guess more anecdotally, since there's hasn't been kind of published data about it, but it does seem that patients have more cytopenias. They do seem to kind of drop
Hmm.
their counts a little bit lower, a little bit longer when they're getting oral decitabine than IV. And so that is something, it's nothing that we can't deal with in the world of, MDS and leukemia. We're very, comfortable with low counts and transfusions, but that is something that I have noticed. So that might be something that is making people shy away, I suppose. Um, the other thing I will say is a lot of our patients are quite old and a little bit frail with MDS and AML. And so you want to give them the ease and the comfort of taking a pill, but you also worry a little bit sometimes when people are taking all oral triplets, like are they really taking it the right way? Are they taking the right chemotherapy drugs at the right times on the right schedule? And so sometimes, having a patient come in for a very short, infusion or a subcutaneous injection, you know exactly what they're going to get, and you can lay eyes on your patient and make sure they're doing okay. So there is, some truth to that too.
And I've heard people say too, the patients are there all the time getting counts, et cetera, so they have to be there. So, one final question: with the another pan tumor approval, like in the last couple of weeks, TDXD and HER2 positive, I'm really curious to see how that plays out. But I was
Yep.
also curious, and I didn't realize another your particular interest. It seems like is IDH specifically. I don't know. You seem like you're the IDH person there at MD Anderson, or is it one of the main ones? And I was just curious. Again, getting back to that, of course, we've been talking about IDH inhibitors and, for example, biliary tract cancers, and I hear
Hmm.
cases along the way where all of a sudden some weird, common tumor you would never expect, all of a sudden there's an IDH mutation. So,
Yep.
do we know anything about whether these IDH inhibitors work outside of, AML and I guess biliary tract cancer?
Yeah. There's IDH1 and IDH2. IDH2 mutations are almost exclusively found in hematologic malignancies, but you will see them in like certain T cell lymphomas, as and there are some patients with gliomas with IDH2 mutations, but far more frequently are IDH1 in various solid tumors. So you mentioned, cholangiocarcinomas have a pretty high rate of IDH1 mutations. Also, certain sarcomas like chondrosarcomas, gliomas, and so they're at least ivosidenib doesn't have great blood-brain barrier penetration. Olutasidenib, it sounds like actually does have decent blood-brain barrier penetration, but there is a third IDH inhibitor. It's a pan IDH inhibitor, actually called vorasidenib, which hits both the IDH1 and the IDH2, and it is blood-brain barrier penetrant, and it has been evaluated with positive results in the glioma population. So vorasidenib is something definitely to be paying attention to in the solid tumor world and gliomas in particular.